Good afternoon and welcome to everybody online to the Independent Health and Aged Care Pricing Authority's online webinar on aged care cost collections. My name is Peter Derrett and I am the Director of Aged Care Policy at the Independent Health and Aged Care Pricing Authority, or IHACPA. I should take the moment then to say that we will be referring to it as IHACPA instead of the Independent Health and Aged Care Pricing Authority. We might say that too many times, go blue in the face. This is IHACPA, sometimes referred to as the agency or pricing authority. The takeaway is we're referring to our organisation and the work that we do. So if there's any clarity, I hope that provides some additional clarity on how we will be referring to our organisation moving forward. I would like to start the session by acknowledging the traditional custodians of the many lands on which we are meeting on today. For me, it is the Gadigal people of the Eora Nation. I recognise their continuing connection to land, water and culture, and respect the elders today and those who walk in spirit. In today's session, we will be introducing IHACPA's role in aged care cost collections, followed by a live Q&A, and I will be moderating and participating in the Q&A panel along with IHACPA colleagues who are with me on the main stage now. We have Julia Hume, who is the Executive Director for Costing Data and Infrastructure. Welcome, Julia. And we also have James Chen, who is the Director of James. Before we start, can I direct everyone's attention to the Q&A widget in your browser window, which you can use to post questions to the panel. You can also upvote other audience questions that are of interest to you, and feel free to start posting questions prior to the commencement of the Q&A session. So there's no need to hold to the end and try to remember what question you had as per slide 11. Feel free to jump in as it comes up, and you can provide those questions or points of clarity or things that you would like to seek further discussion upon by the panel later on to make sure we don't miss that during the process. With that said, I guess it's without further ado, we should start the presentation, and I will hand over to James, who will provide an outline of the aged care cost collections for IHACPA. Thank you, James.
All right, thanks, Peter. So we'll get we've got a slide presentation to start off with, and we'll get that underway.
So welcome to today's webinar on aged care cost collection. My name is James Chen. I'm the Director of Aged Care Costing here at IHACPA, and I'll be running through the slides today with you. So who are we? So as part of the National Health Reform Act, the Independent Hospital Pricing Authority was established in 2011, so known as IHACPA. In 2022, amendments to the National Health Reform Act and Aged Care Act expanded IHACPA's remit into pricing advice for residential and in-home aged care. Subsequently, were renamed the Independent Health and Aged Care Pricing Authority, or IHACPA. So the main work program of IHACPA is to promote and contribute to the improved efficiency in and access to public hospital and aged care services through the provision of independent advice to the Australian government. So within the larger landscape of aged care, there are several key government agencies who contribute to the governance of the aged care system as a whole, including the Department of Health and Aged Care Quality and Safety Commission, the Australian Institute of Health and Welfare, Australian Commission on Safety and Quality and Health, the Inspector General of Aged Care, National Aged Care Advisory Council, the Council of Elders. More specifically, in relation to pricing, IHACPA's role, as mentioned earlier, is to provide advice to the Minister in relation to aged care. The Department of Health and Aged Care is the systems operator, so they'll implement funding and pricing, while the Minister for Health and Aged Care will set the price following IHACPA's advice. Costing is the process of allocating a financial value to account for the resources used in delivering care to a consumer based on individual need. So it's essential to understand what the drivers of cost of delivering care are. For example, this may be staff time, staff mix, interventions, or products. So accurate and standardized costing is essential for activity-based funding. So as part of the price setting cycle, cost collection is an important step. So the diagram shows the pricing cycle that IHACPA uses, with policy leading into classifications, cost collection and costing, and then finally the price. So accurate cost data underpins accurate price setting. Cost data collections are informed by policy and public consultation and are used to understand cost drivers and the variation of costs within the sector. Cost and activity data is used to provide evidence-based pricing advice and to refine classifications over time. Costing is really important because costing enables us to understand variations in the delivery of care across different services, patient demographics, and classification groups. So collection of costs enable us to create a broad data set showing differences across the sector, which forms a basis of price setting. It also informs the refinement of classifications as they change. And now on to more specifically residential aged care. So just some background into the residential aged care space. So as mentioned earlier, in October 2022, the aged care sector transitioned from using the aged care funding instrument, ACFI, to the Australian National Aged Care Classification, ANAC model. So in 2023, IHACPA conducted cost collections for the residential aged care and supported home space, which will contribute to the development of data collection specifications and data acquisition methodologies for the aged care sector. So collection of quality and representative data, including costs, time, and activity, is paramount to allow IHACPA to provide advice to the Minister in relation to aged care pricing and costing matters. So the data collection exercise will form the basis of future pricing and classification development that IHACPA will carry out. So the residential aged care costing studies for the RACCS included a rigorous sampling framework to ensure that the data collected was representative of the diversity of facilities across Australia, including consideration of location, ownership size, and the needs of residents. So expressions of interest were for participation were sent to 989 residential aged care providers in January in 2023, and participation was voluntary, with 118 facilities agreeing to contribute data to the RACCS. So collecting time data within the residential aged care facilities over a period of 30 days. Costing is a complex process used to understand what resources are utilised for a resident. So within the aged care sector, time is a key driver for the cost. Collections of some financial and operational data to inform the costing process. Participating sites were provided with data insights for their facility, so benchmarking their specific facility to the wider cohort. So data has been aggregated to a level to ensure that anonymity of the residents and staff members, so no one will be identified. And the final report is now published on the IHACPA website. So following the residential aged care costing study, IHACPA is looking to implement an ongoing cost collection process to ensure ongoing recency of cost data for accurate pricing. As such, IHACPA will be starting a cost collection for 2024 in the coming months. So just some information about the cost collection for 2024 and some reasons why, the benefits that you'll have to participating. So we're currently recruiting for participants, and it's going to be a time and motion costing study similar to the costing study that we did in 2023, but with a larger and more robust sampling target. So by participating, facilities costed data will influence price advice to the government. So you can be part of that data set that ultimately influences the price advice. You can contribute to our understanding of the cost that's required to provide care to a resident on an ongoing basis. By participating, you help us inform the development of aged care costing standards. And additionally, you'll receive your facility's data insights pack, so providing you with a benchmark costed data summary specific to your facility. And moving on to the supported homes. So in October 2022, the federal budget expanded our function to include the provision of pricing advice for supported home aged care services. So the new supported home program will be implemented from 1 July 2025, and IHACPA will provide pricing advice for the schedule of in-home aged care services based on available data, and advice on how pricing of in-home aged care services can be refined over time as more evidence emerges on the cost of service delivery. In 2023, IHACPA undertook a supported home costing study. The 2023 supported home costing study formed an introduction into the supported home landscape to understand the sector's existing cost structures, current infrastructures, business systems, and programs used by providers for data collection and reporting. So a total of 48 in-home aged care providers participated. And the in-home aged care program included Commonwealth Home Support Program, the home care packages, and short-term restorative care. So the Support at Home cost collection for 2024 will leverage the findings of the introductory Support at Home costing study for 2023 to develop a comprehensive cost and activity data set within home aged care sector. Through the 2024 cost collection, we'll seek to refine previous costing study approaches through expanding the costing study participation, refining costing methodology, improving data quality assurance methodologies, recommendations to move towards a regular cost collection. The Support at Home cost collection for 2024 will include Commonwealth Health home support programs, home care packages, and short-term restorative care. So why should you participate in the Support at Home cost collection for 2024? So increased representation across underrepresented geographical location, provider types, and service types will help us provide a better costed data set. So by participating, it'll build our understanding of current service provisions, data maturity, business systems, and drivers of cost variation. It's going to help expand our data sets. And finally, similar to the residential space, you'll be able to receive your facilities data insights pack, providing you with benchmark costed data summaries. So as one of our participants spoke to in the 23 cost collection, it's good to be part of something that can support and improve the aged care industry, and that's what we hope to do. So our next steps. Ultimately, the goal of our cost collection is to obtain accurate cost data to inform price advice. As we move along the journey of cost collection, we hope to be able to enter a more regular and standardized cost collection cycle, ensuring that your participation from this journey will ultimately lead to costed data that will accurately represent costs being incurred across all residents and clients. So if you have any further questions or would like to be involved, please don't hesitate to contact me on the email listed, so agedcarecosting@ihacpa.gov.au. Otherwise, if you would like to stay informed with our upcoming events and consultations and cost collections, you can subscribe using the link there or the QR code on your screen.
And thank James. I think we can move obviously to of the webinar today, and I can already see a few questions coming in, so forgive me, I'm only as fast as I can scroll with my hand, so it might be a bit delayed. And we have a good amount of time for questions, so there's roughly 40 minutes if needed to go through the questions that you've put on the line. Naturally, if we run out of questions, we won't prolong this unnecessarily. And if you do have any questions, to post it via the Q&A widget. You can find that in the browser. And as I said earlier, you can also which I can see people doing quite well, which is upvoting other audience questions that are of interest to you. That kind of helps flag on my end what to bring up to the panel for discussion. And I guess I'll start with, I can see there's a question there as well. And the question is, the aged care, which I asked you, Julia, if that's okay. The aged care sector is already short-staffed, and what impact will this additional reporting bring on?
Thanks, Peter. And just acknowledging, we've seen a couple of comments come through about the quality of sound. So hopefully we've been able to address that. But thanks for letting us know. So when IHACPA have designed the residential aged care costing study, as well as our first foray into support at home, we have been very aware of the burden that these projects may have on aged care providers, and we are acutely aware that we do not want to add any unnecessary data collection, and we're trying to be really careful in how we design projects to use data which is already collected and use it in a timely fashion. So we are primarily using the aged care financial report, which is submitted by facilities and providers to the Department of Health and Aged Care to inform our financial understanding of aged care providers. Also, we are actively supporting aged care providers, and so those that participate in the costing studies, will receive phone calls, and we will walk people through how to complete or participate in the study, to try and make that as easy as possible for everybody. And we really appreciate those that are able to participate, and we understand that not everybody can participate at this point in time.
Thank you, Julia. And I think they have another question in the chat, which I might throw to you, James, if that's the case, which is, what is the projected time and resource impact of being a part of the costing study for home care? If you could speak to that, please.
Yeah, definitely happy to speak to that. So the in-home aged care cost collection we're primarily looking at trying to get some activity data to supplement the financial data that we're receiving through the IHACPA submissions as well. Look, we understand that the burden may vary according to existing systems that providers have in place, but what IHACPA will do is best understand what systems there are in place for in-home aged care providers at this stage and what they're recording, and trying to leverage what they have and work with them to be able to get enough data to be able to have accurate costs for services provided within their services. So, that the answer to that varies according to each provider, but we are looking at trying to support you as much as possible. In terms of timing, we are hoping to start collection within the next few months and go from there, but we ideally would like a large collection period, knowing that there are other reporting requirements for the sector to be part of as well.
Thank you very much. The next one I have in the chat are about the time frame. So what are the time frames for the support at home costing study for 2024, and specifically when will the results be released, and the subsequent pricing schedules, for the support at home be released as well? That was part of the question. Forgive me for cutting you off.
I know, I'm happy to answer that. I think following on from the previous question, look, we are trying to design and we're trying to look at the best ways to get these costs. So we are just in the final steps of trying to design the next cost collection and what that looks like. In terms of, I think the second half of the question was what the price cycle. So at this stage, the price advice is to be determined by the minister, and that's a decision for the minister to announce.
Thank you. The next question we have, which Julia, I might ask if you would like to have a go. It is just, given the work by Stuart Brown, do you expect to arrive at a point where your data set provides a different cost of care?
Thanks, Peter and Alistair. I'm not sure if it's a different cost of care to Stuart Brown or a different cost of care of what we're seeing at the moment. I expect that, we have undertaken one quite large residential aged care costing study at this point in time, and I'm really keen to start the next one, so that we can really understand the impact of, once AN-ACC's been introduced, how that then impacts the reporting of costs. I don't think it should vary significantly from what Stuart Brown are reporting. However, I can't speak for the Stuart Brown reports.
Thanks, Julia. I think I just had a question for James. I know in the presentation we spoke about sort of benchmarking reports, and obviously one of the key hopeful takeaways, besides educating what IHACPA does for cost collections moving forward, but is also try to get engagement for Resi and support at home. So I was wondering if you could maybe further expand on how facilities and support at home providers are able to use the benchmarking reports that we create on that tool, if you...
Yeah, happy to go through that. So with all participants in both the Resi and the support at home cost collections, we aim to provide them with a insights pack, and basically the insights pack will outline the processes that we went through for data collection, as well as some specific data relevant to their provider or facility. which shows their costs per either resident for residential aged care or service type if they're a support at home provider, and to allow them to, understand where they sit when measured across the average or with similar cohorts. So similar providers, similar size providers, or similarly located providers. In terms of how this is useful for them, it provides, insights to it. And, historically within other cost collections that we've done within the private sector, it allows them to facilities or providers to understand their costs and their workflows around that and how that's different from the average.
No worries. Thank you for that. The next question, I'm not sure, Julia, if you wanted to speak to this one, but it's what information did the initial costing study derive for the various service types in the home HCP and CHSP? Oh, sorry, it's just moved now. Forgive me. And are there any particular service types you would like to see included in the next study?
I might ask James to touch on this. I'll just start by saying that, we know that the service list of the list of services which will be covered under the Support at Home program is still being developed. And so ultimately, I think it's really important that we make sure that we cover those services as per their definitions. But James, did you have anything to say on the outcome of the original study?
Yeah, happy to jump in. So just to echo Julia's point, so we were working off basically the service lists were indicative and potential service lists prior to any formal policy being finalised. So between CHSP and HCP, there were some differences in similar services and the cost of those being provided across different services. But there, again, as echoing Julia's points, there were no formal definitions between those just yet to be formalized. So we expect that once the definitions of the subcategories and the services to be placed in, that we'd see some more homogenous prices across those. And in terms of the future cost collections, so, our costing cycle, as shown in the presentation, we go through a few different things, and costs and cost collections are kind of pivotal and underlying data sets. So it's something that we can't, and they take a lot of time and resources to do. So we can't do them at the drop of a pin. So we do like to try and get in early so we have as much data as we can to be able to inform pricing. But our intention is to align the services across both CHSP, HCP, and short-term restorative care to the definitions that will be outlined in the final policy as much as possible.
Thank you very much. And then we have a question, I think, building on the sort of the benchmarking reports and the data in the past. It says, you indicated those involved will receive data insight packs. Has this information from previous studies been de-identified and summarized, and will it be shared with the sector?
So I'm happy to answer that following on from the previous question. So those packs will be sent out to the individual providers or facilities. It is up to them on how they use it. So they will be identified because we believe that the cost data that we're collecting is the facility or the provider's data. Aggregate results are published. So for the residential aged care costing study for 2023, a lot of the average costs were published in that, which is now live on our website. But individual facility results will not be published in a live environment by IHACPA.
Thank you, James. There's another question, I think, which is voted up, which is top-down and P&L data has traditionally been a terrible way to understand costs. Will IHACPA focus on more bottom-up data, like care delivery observation and costing? Julia, would you like to turn your hand to that question?
Yeah, nice costing question. We certainly think that bottom-up costing is more reflective and should incorporate, the resources. And this is what's really important, incorporating the resources that each resident or consumer of these services requires when receiving care. I have more of a background in the hospital costing space, and we know that the inputs to hospital costing are really varied, and there's a lot fewer inputs in the aged care sector, especially and when we've looked at the residential aged care sector, we have done some projects which record how much time residents receive care from staff, and we use that to allocate costs directly to residents. So we're certainly looking at that resource allocation costing approach, the bottom-up costing approach, and we'll continue to do so. And we also think that there could be more information that facilities are already collecting that could inform that.
Thank you, Julia. There is a question, well, there's lots of questions, but any resources or information that can be provided for review before a provider or service decides if they'll participate in a future cost collection? Just adding extra words to that, but that's the gist of the question.
Yeah, no, I'm happy to take this on. So when we finalize the project methodology and what we'll be specifically asking to participants, we will provide all those details to them before they participate. I guess as part of this, we're trying to encourage as many facilities to be part of the cost collections, or at least express interest. And we do understand that in certain circumstances, it's just not feasible to participate in a cost collection in the timeframes that we require at this stage. But definitely, if anyone's interested, they can put forward their names, and once we have a solid plan of what we're going out to collect and how we're going to do it, that will provide all that to the participants and let them make a call. But IHACPA will also, I guess, work with the facilities and the providers to be able to, I guess, overcome any questions they have, any concerns they have, and work with them in terms of timing as to what's best for them, to make sure that they, we're doing everything we can for them to participate.
Thank you. We have a question that says, given the ACFR and QFR are retrospective, how will future cost impacts be considered? For example, the recent wage increase from the Fair Work Commission. Julia, in sense of sharing, would you like to have a start?
Yeah, so I always think there's two really important components, and one is there are times when we are looking at the cost associated with care being delivered in a facility in a particular point in time, and that is often retrospective. And in the example of the Fair Work decisions, we are aware that those decisions are not present in the cost data that we're looking at, for example, from last year. When IHACPA then starts to develop pricing advice, we do consider other relevant costs that need to be considered and included in that price. And we're developing processes to ensure that we do that appropriately. But often I like to look at the costs at that point in time without adding or manipulating it any further.
Thank you very much. The next question is, which I think I might have a chance at speaking to, which is, does IHACPA have any influence over the viability supplement and the issue for the modified Monash model 3 to 4, or MMM 3 to 4, not receiving any supplement despite significantly increased costs in these regions? I think from the policy perspective for IHACPA, we are quite limited in kind of what we can do, and obviously through the National Health Reform Act, a lot of our processes and information come directly from the Australian government. So we get direction through the ministerial expectation setting paper if there are particular pieces model that we can look at, or the classification in future stages, and actually part of that is back increasing the data sampling to understand how to best inform any decisions or proposals that we make, because obviously I think that the key takeaway for aged care on behalf of IHACPA is that we provide pricing advice to the Australian government. We don't determine the price. That role is still with the minister and government to do so. So with that said, I think there's a long conversation that's still ongoing, that we work closely with the Department of Health and Aged Care. And I note that with viability generally for the sector to go broad, I know that's a responsibility for the department and the Aged Care Quality Safety Commission. And currently, we haven't been asked specifically to look at the viability supplement for the MMM3 and 4 regions or areas, though there is ongoing conversations with the government to understand if that's a key priority area and how can we support with our pricing advice and the data collection that we give up to them later on. So I hope that answers the question. I know it's a bit like not trying to pass the buck, but there is limitations to what IHACPA can do. So we are slightly constrained by our legislative intent as well. The question we have is, what is the role of IHACPA in setting the CHSP prices? I guess for a lot of the sport at home at the moment, there's not a lot we can comment on at this point in time. And once again, all we can say is we are working closely with the department in the finalisation, which is within their remit, and naturally that has to go up to the minister for their consideration and the Australian government and actually come down to us. So there's not much more we can say on that at this point in time, but we are working once again with the department and the commission, not the commission, that's working with the department and the government in the finalisation where we can and influencing. So the next question I have, and forgive me, it's moving slowly on my end to scroll. It says, will pricing include the costs of implementing the new age and the cost of implementing the new support at home, e.g. the project, governance, technology, etc.? That's a great question. I think
Thanks, Peter.
at this point in time, oh, here you go, Julia. Thank you.
Yeah. Hi. So we would expect the cost to include, like I want to say, things which are relevant to the provision of care. And we know that sometimes costs are one-off. One of the things which we have identified in our work program, which we would like to develop, are costing standards. And these would effectively help everybody understand what are considered in-scope costs for the purposes of support at home services and residential aged care services, so that we have a consistent approach and for the purposes of reporting within the ACFR or QFR, as well as for the purposes of allocating costs to relevant services, that we have a consistent in-scope selection of costs.
Thank you. Another question we do have is obviously about the support at home costing study for 2024. And will you, IHACPA, consider the costs that we may be experiencing as we prepare to reform to the support at home? Or these are additional costs that are time sensitive. So I'm not sure if James or Julie would like to speak to, or if we can speak to.
Like, I think if those costs are being reported in the ACFR and have been identified as relevant in-scope costs for the purposes of delivering care, then at this point I would expect that they would be considered. I'd have to understand a little bit more about what the exact costs were.
Thank you. The top question I have at the moment is around, given most providers are paying above award rates to attract staff, will award rates be used as the basis to cost time?
Happy to go through that, I guess. Or unless Julia, you want to jump in? I was going to say, I was going to say that with the costs, we're going off what's reported costs. So the facility is paying above award rates, and that's what's being reflected in the ACFR or QFR submissions. Then that's what we'll be going off. So we will be looking at what they're paying. So, you know, we are trying to understand the true cost of care through these pieces of work, whether it be apps per resident or per service type. So we are basing it off what's being paid at the specific facility or provider that we're collecting those extra additional points of data for. Julia, do you have anything to add to that?
No.
Thank you. There is a follow-up question. I think someone asked a question before, so just try to bring continuity there. It says, what about the aggregated result P and the CHSP? Oh, it's difficult when. Sorry, forgive me. I start reading and then it shifts.
While you find that question, Peter, I did see another question pop up in relation to de-identification of data, and we do take our obligations really seriously in relation to treatment of protected information. And IHACPA, we have no intention to publish any information which is identifiable. And we, for the purposes of public reporting, we aggregate data, and there are a limited number of situations, such as those that participate, where we will give that facility or that provider a benchmarking report which would contain their specific information, but we did not make that more publicly available.
Thank
and
you,
the
Julia.
report on the residential aged care costing study that we undertook last year has been published, but the support at home project has not yet been finalised, so there's no information about that publicly available. We expect that will happen later in the year.
Fabulous, thank you. Sorry, I was just trying to find the question and I've lost it, forgive me. It was, what I was trying to ask before, which I lost now, I found again, forgive me, which was what about the aggregated results for HCP and CHSP of data insight studies? Are these available in a summarized and de-identified report? I think you kind of answered that, which is it will be published in time and they will be de-identified. So sorry, just circling back that has been answered. The next question that I can see is about staff travel has been a critical cost factor, yet the DEX reporting specifically excludes this, and a question to ask at this factor.
Yes. So with staff travel, happy to go through that. And with the DEX stuff, I believe that's a lot in the CHSP world. Basically, if we're looking at basically entire costs, if these costs are being reported and as part of the care management of the services that are delivered, we will take that into account, at least in our costing study. I guess how that translates to the final price really depends on what the final policy outlines in terms of what should be out of scope. And I know, sort of following on that, there was a question about a lot of CHSP providers do not complete ACFR and QFR. They're not out of scope. So for us, we did look at CHSP providers and we did look at the acquittals that were provided to us as part of the support at home costing study. And we do appreciate that ACFR and QFRs are quite foreign to the CHSP providers. As such, we did try to align as many of their, request as much of their financial data in line with what those ACFR and QFRs were. As we move forward, we are looking at, better ways to do this until CHSP becomes part of the larger program.
Thank you. And we do have a question that is, I think, similar to the CHP's vein of thought, which there's 900 plus CHSP providers that do not complete the ACFRs and QFRs. Are they out of scope? I guess is the question.
Yeah, so I think I've touched on that briefly before. That the CHSP providers don't complete the ACFR or QFRs. In the last cost collection that we did in 2023, we did ask them to provide. We looked at their acquittals as well as any of the DEX data or existing financial data that was available. But for anything that wasn't specifically reported or we needed additional information for, we did request that data in the same format as ACFR and QFRs. But yeah, as you know, we will continue to work with all sectors of the in-home aged care provider landscape to make sure it's as smooth as possible and to include as many of those CHSP providers as possible. We do, I do appreciate that the CHSP isn't going to be included in the 1 July agreement, but we understand that at some point in the future we'll come across, and when that happens, we'll revisit the way that we get that data from them.
Thank you. There's a couple of questions in here about IHACPA's 2024-2025 approach to indexation and the ENAC weighting units. I guess the only thing I can say at the moment is process that we would receive the data from the previous residential aged care costing study, and we did the analysis of that. We had a consultation that was conducted last year as well, that we had great feedback from the sector and helped inform our pricing framework. Documents have been sent as draft versions to the Minister for their consideration. So there's nothing that we can comment on at this point in time, but as per our values, we are transparent. So we do publish all this information once it's been finalized. And so on our website in time, you will find a summary of the consultation report, the pricing framework, which is our policy document about what we're currently doing, what we look to do in the future, our pricing advice to government, as well as the technical specifications, which will break down the sort of indexation methodology and all the maths that the organisation do run through for. So that will be all published in time.
But so it could also be useful, Peter, the technical specifications for the pricing advice for the 23-24 period are available. And in terms of people becoming familiar with how we have undertaken that work, they're certainly available on IHACPA's website.
Thank you. There is, and thank you, Julia, forgive me, I did miss that. Thank you. I'm not can talk to this question, but I'll ask it and see what we can find. As based on the updated data in my aged care around financial operations, it shows a deficit of $10.90 per resident per day. This seems significantly high. Do you have any information on how this data is audited to confirm your costing assumptions? So I'm not sure exactly. Julia,
yeah, thanks.
Have a go.
Yeah, thanks, Peter. I'm happy to take this question on notice, and perhaps we can contact Chris at a later point in time. We do work closely with the Department of Health and Aged Care in relation to how they receive the ACFR and the QFR, and a number of the checks that they undertake on that data. And so we work with them on that. In relation to the $10 deficit, I'm not able to comment on that, on how that was calculated. Sorry.
Thank you. There's a question for the support at home costings about will the support at home costing study 2024 consider the underlying cost basis associated with organisations who provide both aged care and other sector services such as health or disability or home-based care?
So where, Julia? I was going to say, where we do understand there are a lot of providers that provide similar services across multiple programs. We are, for support at home, our remit is really for what is in scope and what's been defined through, the support at home program. So we are looking at those specific costs for support at home. I can't comment on if there's going to be adjustments made for those who have provide multiple, similar services across multiple streams of work, but happy to take that on notice and, happy to keep that in consideration.
Thank you, James. Another question around representation is, how does IHACPA ensure that including geography and other types of services? So maybe that talks about our costing methodology, approach, and engagement. Julia?
Yeah, I guess.
Or James, forgive me.
I was going to say, for our cost collections, we do try to be as representative in capturing the wide gamut of differences in, location, size, specialty and services provided. And, that's definitely a consideration that we have for the support at home space. I guess how, there is a limit on, collecting the entire gamut and the resources required for that, but we do aim to create as representative of a data set as we can. Julia, did you have anything to add? Yeah. And I guess, that's part of what we're trying to do today, is to try and explain what we're doing and have as much interest into that, into participation as we can, because we do know that some of the smaller, I guess, demographics in terms of, rural, remote, and specialty services can be, there is a very small sample of those within the larger landscape of both resi and in-home aged care. So we'd love to, encourage those people to be part of these cost collections, so we can really understand the costs and the cost drivers in those areas.
Thank you. I have a question as well around maybe just a broader question about how IHACPA, how we were able to provide provide how IHACPA comes to a price as well. Because I think obviously cost collection is a part to drive to a price, and maybe just also deliver that sort of pathway for the broader audience might be helpful.
I think the actual, I'll just refer again to the tech specs from last year, which are the technical specifications of how we develop the price advice in relation to residential aged care. While we think that collecting new information is really, really important, we also know that we're just starting to collect information directly from aged care providers ourselves. And the data we collect is used alongside a lot of other data collections to inform that price development. And we do. We also know that the data that we've collected is quite a small sample, and in some cases we haven't been able to collect a representative sample either. And so that is certainly considered when we're developing price advice.
Thank you.
What I might
Julia?
do, I think
question
there have been a few. Sorry, I was going to say there's been a few questions about this, the insights pack. So what I might do is I've got a DIA or an insights pack which has some dummy data in there that we used in the residential aged care costing study that I might share on screen with participants, just to have an insight as to what kind of information you would get. So just to make sure everyone understands that this is all dummy data. Some of the averages in there were the averages that we used, but they're all publicly available in our report. But any of the other data in here has just been inputted at random. But basically, for the 2023 residential aged care costing study, there was a PowerPoint slide deck that was provided to participants participants. It outlines the background about what the costing study involved. My screen is sharing.
Yep.
As well as the interpretation of, a background about what all the figures mean. Similarly, about the methodology that we looked at and what points of information that we were looking at. Some overviews of the facility or the provider that was part of it. So including the number of, for residential, the number of residents, how many interactions they had per day, as opposed to the total costing sample. Some graphs specifically around the averages of their data collection period, the average daily minutes, by different metrics such as staff role, by classification and staff role, and multiple other metrics, and by shift, and some loose interpretation around what we've done with those figures, and costs across different categories and overhead categories as well. So I hope that provides a little bit more information about what you would be getting as a participant. And I'd probably just like to reiterate that none of these are personally identifiable. As Julia said, we take privacy quite seriously here. So there are no residents that are identified in these individual data packs as well. And there's no specific staff outside of their staff type that's being shown. In the event that there are low numbers of a certain staff type, such as some allied health subcategories or pastoral care or some of the other categories, we would choose to suppress those in the report as well to make sure that no one is identifiable from that. If there was a low number of certain ANAC classifications within a facility as well, we would amalgamate that. So if, for example, if there was only one Class 2 resident within a facility, we wouldn't want to pose any of those individual, we want to show the averages of the Class 2 for a facility, because that would be quite identifiable. We would amalgamate that with another class, just so we could show that as well, and would make that all very clear in those participant packs.
Thank you, James. There's a question around, obviously, usage of other data sources as well. So it says, we have previously been involved in a pricing study completed in partnership with a university on pricing. Would you be open to looking at the data from previous work such as this? Maybe throw to you, James.
Certainly. And we'd be happy to, if you can send us an email, we'd be happy to have a discussion about that in the first instance.
Fabulous, thank you. Sorry, my chat's freezing. Apologies. So
okay, there's a question. So in that case, Peter, there's a question in relation to agency costs and how we consider those, and regional providers given weightings, considering it wouldn't be fair to allocate as much to metro providers who don't have the same agency costs, including hours needed, accommodation and travel costs. Again, touching on what James said earlier, we are really looking at what costs are being reported, and the slide pack that he just went through very quickly in relation to how we look at those and benchmark them. We do consider the data we collect by remoteness, by different cohorts of recipients or residents, as well as like size of facility, and the ANAC N class. And during the pricing development phase, all different combinations of those are considered to identify where adjustments may be required. And so as long as the costs are reported that are associated with agency staff, then yes, they are at this point in time also included. as the cost of delivering care.
Thanks,
Okay.
Julia. I do apologise. It's still frozen on my end.
Okay. There's another question about in previous years, there was a financial contribution for participants. Is this no longer an option? In the costing studies that IHACPA have undertaken to date in relation to aged care, we haven't gone down the path of a financial contribution to participate in those studies. We have considered it. From our experience, it doesn't always result in getting good quality data. And we've really focused our efforts on trying to reduce the burden on those that participate in the studies, and also try and provide as much support as possible, rather than provide a financial assistance at this point in time. And there's another question there from Renelle, asking confirmation about when the 2023 home care report will be released. And are we asking that people participate in the next study before they see the results of that report? That may be the case. But I think what's really important is that we support the sector, and as you know, in our development of pricing, like, we know that the most up-to-date information is really critical for developing price advice, which is reflective of the costs which are occurring. And sometimes, and it certainly happens in the hospital space, you know, that more data is being collected before, you know, often before the previous year's data collection has been, you know, completely signed off, just because of all of the different reporting requirements, quality assurance requirements. And we hope that in the coming years, we'll develop a cycle of data collection, data reporting, pricing. And we also always try and be really clear with those people, the stakeholders that we're working with, of where we're at in that cycle. Peter? James?
Yeah. I think
Yes, sorry, it's
we're
apologize.
yeah.
James, is there any last question you can see?
I think there was a question around location-based costs. You know, locations, we're definitely looking at our sampling strategies are always looking at both jurisdictional and rurality-based sampling. So we are looking at those differences in costs according to those. There's a specific comment about Victorian payroll tax. You know, that's something that we'll consider. That, you know, how that plays out in the final price is something that we'll need to consider and work through, and see what the evidence says through the cost collection. And I think that brings us to time, and I'll throw to Julia.
Thanks, James and Peter, and thank you everybody for joining us today for this webinar on aged care cost collection. And we hope that you found the session useful in understanding IHACPA's role in aged care cost collection for both the residential and aged care spaces. If you have further questions or you would like to express an interest in participating in these upcoming cost studies, there will be an email. You'll receive another email this afternoon, and that will include a link where you can register your interest. So thank you very much for joining us today.